Hi, guys. Dr. John at the Voyage Clinics podcast. Dr. Rebecca Bernard joins me today. She's a medical doctor in Florida. That's where I did my med school and residency. I'm excited to have you. Um, yeah, Voyage Clinics podcast, as always, is our objective is to just bring knowledge and goodness and to the community as family docs. And so I'm excited to have you on our podcast, Dr. Bernard.
Dr. Sanders, thank you. Now, where in Florida did you do your training?
Yeah, so I did med school at Nova Southeastern in Fort Lauderdale, so not far from where you did med school in the University of Miami. In fact, I was going to say sometimes we would get a guest lecturer from the University of Miami at our med school, and it was always awesome. They were such great professors, like fantastic.
Well, funny story for me is I applied to Nova and University of Miami. I got accepted to both, and I really, really wanted to go to Nova. It was actually my first choice. And then they said, you have been accepted. In order to hold your position, please send us a check for $1,000. This was back in 1995. And I didn't have $1,000. I have nothing, I was completely broke. And then right as I was trying to decide how I was going to come up with $1,000, I got an acceptance from University of Miami, and they said, just acknowledge this and you're accepted. And believe it or not, that was what made the difference. And then later on, I was young and dumb. I guess I still am a little bit. And was telling that story to somebody from Nova, and they said, well, why didn't you just tell us? We would have waived the $1,000. And I'm like, I didn't know. So I really have a lot of positive feelings about osteopathic medicine. I really wish that I had been able to learn the manipulation techniques. I think it can add so much to your repertoire and for patient experience. So one day I'm going to go take some of those courses because I think it's so awesome. I'm a little jealous that I don't know how to do that stuff.
Oh yeah, we do it every day in my practice. It's so fun. I grew up in a small town in central Nevada. I see you grew up in a small town too in Florida,
I
and
did.
we were 250 miles away from the nearest major medical center. And there was an old chiropractor who was a special forces medic who would come out to my town and he would do adjustments, and he was pretty knowledgeable because, being a medic and stuff. And I don't know. I got accepted to the University of Nevada School of Medicine, and I chose an osteopathic school for that reason as well.
I think you chose very wisely. And then did you do your residency close by to where your med school was?
So I did residency in Jacksonville at St. Vincent's Hospital.
That was on my short list. I ended up choosing Florida Hospital in Orlando, but I certainly interviewed at St. Vincent's and I thought that was a fantastic program. We're really lucky here in Florida. We've got some great family medicine residency training programs.
Yeah, like you, I wanted to do rural medicine, and as a country guy, I enjoy that, and so St. Vincent's offered a kind of a rural medicine track, so we were able to do extra babies and extra OB and C sections and get really well trained, and most all the attendings there are retired Navy docs, because NAS Jax is there,
Right,
and
right.
and it was just great training, just
I bet.
fantastic training.
That's
Yeah.
awesome.
And I went to
And now
Moab to do rural medicine for 6 years after that and doing all the things. It was so fun.
that's amazing.
Rebecca, tell us about your journey. So I'd love to, we're kind of getting into it a little bit. Sorry. So a bachelor's in sociology at the University of Florida. And
Yeah, and that was a deliberate choice because I find it fascinating and interesting, but because my science grades were not going to be straight A's, I was getting pretty solid B's. And I have to admit, I did get a C in organic chemistry too. And I knew I was going to have, I know that organic chemistry. I knew that I was going to have to do something to get that GPA up because I'm sure, as our listeners know, it is not easy to get into medical school. It's even harder now. I even asked if I would have gotten in today, but I was strategic and I thought, well, I'm very strong in the social sciences. That's where really my strengths lie. So what major can I choose where I'm pretty sure I'm going to get straight A's to kind of balance out some of those B's and even that C? And sociology made the most sense. And actually, it's turned out to be really beneficial for me now because, of course, you have to know science as a physician, but there's so much that we use in the social sciences, in psychology. And then for the writing that I love to do, I really call upon that background in sociology and also just thinking about the world around us. So it's really useful. And I'm glad that I went that direction.
It's so beautiful there in medicine. There's right and left brain, and all through med school, I think we're pretty heavily left brain dominant, right? And the sciences and all the anatomy, physiology, and um, it's beautiful to have that balance in practicing. I think it's more art. There's a ton of art in practicing medicine and delivering healthcare. It can be really beautiful.
And the patient relationship. And I think, we sometimes get a little bit stuck in the sciences, especially if we're more brained in that way. And there's a lot to be said about bringing the humanity into it to really get the results. So if I had my way, I'd probably make every doctor do a little more social sciences background before medical school if they weren't already so inclined to do that.
Hmm. I love that suggestion. How would you recommend they kind of go about that? Just take extra classes in undergrad?
I think that, just exploring a little bit more outside of those core sciences, just to expand your mind a little bit, to think about other things, even philosophy and just ways to think about the world outside of just the black and white that we know about the sciences, I think is helpful. The other advice that I would give anybody would be to take a little acting class, a little theater, because sometimes you may not be feeling like your very best day, but yet your patients are still expecting you to give them all of your attention and everything that you've got. And so sometimes I draw upon some of that background that I had in community theater back in my high school days of just, okay, I'm not really feeling great, but I'm going to give the patients what they need, which is the compassionate, caring doctor. And so I'm going to kind of put on that persona. And there are studies that show that when you act like you care, you do start to care. Even just smiling, studies show makes you feel happier. So that's the other advice that I would say. A little bit of theater sometimes can come in handy.
I love that. I love that. Theater and maybe even communications. Like how
Oh,
many
yes,
times
that would be great.
Yeah. Uh, Super great. That's so fun. I yeah, I think just the art of medicine, I've been so enamored by. I teach, I think probably we both teach medical students, and it is so fun. And I often, I'm like, okay, you guys we're drilling the sciences and we're doing all that stuff, but I'm trying to balance them out and show them. Dr. Bernard and I are both direct primary care doctors, and she's in Florida, I'm in Utah. And it's so lovely that this style of practicing medicine allows us to really care for people, connect with them, and to practice the art of medicine. I think not only medical school is so left-brained and it's so, it's science and stats and strategic, which is beautiful and wonderful and important. But then as people get done with medical school and they're plugged into a system that's very much stripped of empathy and compassion and care, and it becomes really difficult to maintain that left brain, right brain balance and to be a compassionate serving physician in the broken system. It's hard.
You're so right. And I mean, it's funny how I'll meet patients and they'll say, I had a really negative experience with Dr. So and so. And I'll think, how can that be? I know that doctor. They're such a caring and wonderful person. And then I come to realize that they have just been beaten down and burned out by the system, and they just really have nothing left to give. And honestly, I've been close in my career to kind of turning into that. It may have even happened occasionally, but I guarantee you, if I had stayed in it longer, I think it would have been hard to avoid kind of being that person when you're put into a situation where it's like an assembly line and you just don't have anything left to give. It's not going to be a good experience either for you as a physician or for your patient. And sadly, I don't see the system reforming itself or getting any better. And so that's one of the reasons that I like to call myself a little bit of an evangelist for direct primary care for physicians and then also for patients, to say there is another way, there is a better way. You have to let your brain go to a different model, because a lot of times people are just so confused, like, well, what do you mean? Why can't I use my insurance? I pay a lot for that. You do, and it's kind of crazy. But it's worth this reasonable fee, which is the other thing I love about DPC is it is, I call it affordable, accessible care. So yes, you're going to reach into your pocket a little bit to pay for that, but that means that now you're getting the time, you're getting the attention. And I would say the value is much more than the $75 a month or $100 a month or whatever that doctor is charging. And John, I'm going to apologize. The sun is coming right in through my window and I'm in my office. So I'm trying to move around to get out of it and it'll probably move soon, but there's very little I can do about it. And
Oh,
I'm so
it's
sorry about
totally
that.
fine. It's
I'm
totally
like,
fine.
what is that coming? I thought it was my light, but it's just the sun coming in through the curtain.
No, it's true. And direct primary care is, I too am a huge evangelist. We both have helped many of our colleagues into the space and we continue to mentor people nationally and help them and it's beautiful. And then explaining it to people and helping them understand that, you pay this much more and you get this much more care.
Right.
I think the one of my favorite things is it really rekindled my desire to be a doc and to continue in this way. Um, and I don't know, it's just recharged my batteries in caring for people. And um, I think there's a little bit of a tragedy that happens as these docs burn out, right? And
It
they
is.
start
It's sad.
performing poorly and showing
Yeah.
up poorly, and it's because they're strapped to so much moral injury and fatigue and all of the bureaucratic box checking bullcrap that I sometimes use a more rude word about. It just beats us up over time. And one of the magics of medicine, caring for people, is trust and relationship. And as we continue on this broken healthcare system, we're literally sawing off those parts of healthcare. Um, and it's a shame because with trust and relationship comes the power of magic. And I want to say magic, but it's like placebo equals like 30% better efficacy rates, whether all they have to do is trust that what you're telling them is true. We lean into evidence-based medicine and saying, it's better than placebo. But like if that person doesn't trust you, then nocebo also takes effect. And then they have 30% less efficacy, even though it's proven to be an evidence-based strategy to help this person. Anyway, I think by degrading trust and relationship, I think we're killing the magic of caring for people, helping them
You
have
know,
good outcomes.
I was reading this article about this phenomenon that happens in psychology called sudden gains, where a person can be in a not a very good headspace and have a lot going on. And within just one session of a therapist or psychologist visit, they'll make a rapid improvement. Not everybody, but a lot of people experience this sudden gains phenomenon. And I've noticed that in DPC as well. And I think it comes from unburdening yourself. People come to us with a lot of fear, with a lot of anxiety, with a lot of trauma from the past healthcare system. And just the fact that you come into a safe and comfortable and homey environment, which is what we try to set up here, and a lot of my DPC friends do the same thing. We make it like truly a medical home. It's like a place for you to come. We sit down, we're not rushed. People aren't rushing in and out. You don't meet a 10 people when you come in. You just sit down with me and you just share what's going on, and somebody listens to you empathetically and validates your emotions and your feelings and gives you some feedback. And by the end of that visit, it's almost like people have just let go of almost sometimes decades of anxiety and fear. And sometimes when people will come in with this laundry list and so many problems in my mind, and especially if I were still in the system, I'd be like, oh my God, how am I going to solve this? And how am I going to fix this? And now I've learned that I just listen, I let them unburden it all. And sometimes at the end of the visit, if I have some suggestions, they say, I think I'm just going to see how things go. And then when they come back, they go, I actually feel a lot better. And it's remarkable, but there is a therapeutic power in the relationship, in having someone that you feel that you can trust. And it's also remarkable how quick that trust can be gained. Of course, it can also be quickly destroyed, but DPC, I think, is just so conducive to building quickly that trust, having patients feel safe, knowing that they can reach out to you if they need anything. It's a beautiful feeling. And it is something that, like you said, it gives you joy. It makes you want to stay in this profession. I had a pre-med student that kind of cold called me and asked me if he could shadow me. And he spent some time and he said to me, I was feeling very discouraged about family medicine. It was something I always thought I wanted to do, but then I went and worked at the system with a couple docs, even my own doc. And I said, I don't want to do this. This is horrible. He said, and now that I've sat with you, I want to be a family doctor. And then he got into FSU for med school. He's in med school now. He's still tracking to go into family medicine. And I feel it's because of DPC that we saved a prospective family doc. Sometimes the critics say to us, well, DPC is going to, you can't take care of that many patients and therefore you're ruining primary care. I say, no, we're saving primary care because these young people see what primary care is in the system. They want no part of that, nor should they. But they say DPC and they go, I think I can do primary care. I want to do that. I don't want to go into a subspecialty. I want those relationships.
Oh, I love that you mentioned the student. I just gave a talk at a local medical school in front of about 240 students, third year and fourth year medical students. And I explained direct primary care. I explained how it works and how it works for patients, how it works for us, how it works for our communities, and building that trust and relationship and the remarkable changes you can have in people's lives. And I shared a few stories and all that. And at the end, it was interesting. I had at least 10 students come up and say, wow, you have literally changed my whole perspective around primary care. And it's true. It's so true that
Yes.
it is. I think that even the AFP, I hate to quote them, but I think one of the one of the leaders said, he said, direct primary care is I don't know if this is right, but I'm just going to do it anyway. He said, direct primary care is the only way, sustainable way to deliver primary care in the United States long term. And I believe that. I believe that for every, 5 docs that burn out in the system and quit medicine, I almost did that. I almost went and bought like a franchise for a restaurant and did
Sure.
something totally different.
So many of my friends are not doing clinical medicine anymore that, were graduated with me because it's just it was too discouraging. And so it really does save us as physicians and our patients. And I think it is the answer to the healthcare system, at least when it comes to the bulk of healthcare in the sense of primary care. There's still issues that we need to address with specialty care and hospital stays and surgeries and things like that. But the 80 to 85% that we can do in primary care, I think DPC is the answer.
Yeah. I want to talk a little bit about your journey, Dr. Bernard. I think it's so cool. You've done some rural medicine stuff. You're from a small town in Florida. And
Yeah.
how many people in that town?
About 5,000. It's a
Yeah.
small town that really shouldn't exist because before they built the city, the Lake Okeechobee, which is the big lake in South Florida, is supposed to overflow every rainy season and send the water down into the Everglades. And it's a beautiful cycle, but that is very rich soil because of the years of that. So back in the 40s and 50s, agriculture people said, we're going to use this to grow sugarcane. And so they grow sugarcane there. That's the big industry. And so I grew up there, a very small town. Every year they burn sugarcane. That's how you get the leaves off of it. You burn the fields. And so every year we would call it Clewiston snow, the ash would come down. And so that was my childhood. Good things about small town is things like you don't have to be a good actor to become the lead in the school play because there ain't nobody else there to
It's
do it.
true.
Or you don't have to be
It's
a very
true.
good singer, and voila, you're in the chorus. And here, do a solo. Why not? So some negatives, some positives. But I did also, because of being in a small town, was able to get some scholarships and things like that to go to college. And then I applied for a National Health Service Corps scholarship to when I got accepted to medical school, because going to Miami, or had I gone to Nova, they're both private schools and they're not cheap. Even public school is not cheap. So I was thinking, I don't really want to have a lot of debt. So I was fortunate to have been granted that scholarship. And at the time that I won that award and I signed up for it, you have to agree that you will work in an area that meets a certain criteria for healthcare need. There's a number that they give it, and you have to do that year for year. So for 4 years of med school, you do 4 years of service. And at the time they said, oh, but don't worry, there's going to be so many choices. Look at the list of all the HPSA, which is what it's called, health professional shortage areas in Florida. I wanted to stay in Florida. I'm from here. So I felt pretty good about it. But then when the time came, there were 3 choices in the state of Florida. So I basically interviewed at the 3 places and I picked the least of the challenges because they all have difficulties, meaning they're in remote areas where there may not be housing. As a single, young woman at the time, where do I want to work and live? One required hospital work. I knew that was out because I get hives when I go into hospitals. I don't like it. So I ended up picking of the 3 a town called Immokalee, which is a migrant town, mostly migrant workers, some people that are from the area. There is a Seminole Indian reservation, although most of their patients from there get care. They have a little clinic there. So I was there for 4 years, and crazily enough, the IRS decided to start taxing the National Health Service Corps scholarship money the years that I received them. So they pulled out money to pay the taxes, and I had to take some student loans to pay living expenses. So I ended up having to do 6 years of service to pay back. The IRS later changed their mind on that. But anyways, I ended up in Immokalee for 6 years. Wonderful patients, very high need, great place for learning, a huge learning curve. It was like a second residency. Our patients didn't have access to specialists. Even those that had Medicaid, most specialists didn't take Medicaid, at least at the time. So I really had to become sort of a de facto specialist in any type of non-procedural field, endo and rheumatology. And it's actually served me very well in direct primary care for my patients without insurance, because I feel pretty comfortable figuring things out and trying to manage to the best of my ability. The biggest challenge that I faced working in Immokalee is working in a federally qualified health center, which had a lot of rules and regulations, a lot of bureaucracy, a lot of layers that made it pretty challenging to practice medicine. And I didn't feel that the staff, myself, the other doctors, the nurses were always really treated that well by our administration. You kind of felt like you were a cog in the wheel. It was sort of a revolving door. The doctors would come, they'd do a couple years and they'd get out. And you would ask the administration, well, have you noticed some common denominator or pattern here? And they would always say, oh, well, this person left because of their spouse, and this person left because, and, there was never any accountability for the fact that, treating people a little bit nicer, a little bit more understanding would probably get you a lot further. So I did my 6 years out there, got all my loans paid back. And then I was like, I need to see if things are any better anywhere else, because I was getting a little burned out. I was getting some compassion fatigue. It was a terrible story that I had happen to me. Was one of my patients was murdered by her husband. You might have to put a trigger warning on this now,
Mm.
in a very awful way, where he took her body to the Everglades and, for alligators. And so it was in the news like crazy. And she was my patient. The husband wasn't, but her parents were my patients. Her children were my patients, her grandparents. So it was so distressing. I asked myself, did I miss some domestic violence? I had that guilt. Then I had the grief of all these people. And it was so hard and hurtful. And then what happened was other people would come in with their concerns like, well, my kid, is addicted to drugs and he just stole all my money. And I'd be like, uh-huh. Like, well, did your husband kill you? Or I mean, I got so jaded because I had heard these horrible, horrible stories and so much of that I started to just almost like nothing was phasing me anymore. And it was compassion fatigue. I couldn't. And at that time, I didn't have the insight to realize that I should get some help and that I needed to talk to somebody and I needed to maybe set some better boundaries or whatever I needed to do that now I understand, but I didn't at the time. So at that point, I just said, I need to get out of here. I need to do something else. I was offered a job working at the complete opposite. So I was taking care of the poorest, the most indigent, the most neediest patients. And in Collier County, where Immokalee is also Naples, Marco Island. And so you have a county that has the poorest and the richest patients in the state of Florida. So I was offered a job at the for-profit hospital doing outpatient work. And I thought, this will be interesting. Let's go to the complete opposite. And it's got to be better. I'm sure that the administration will treat us so well because we're taking care of this different patient population. And wow, what an eye opener that was, because I didn't have the same problems with my patients. I could get them in with all the specialists and whatever meds they needed. But the administration was exactly the same. It was just like, you're just here to do your job. Don't complain. We don't want your feedback. This is how we do things here. And I have to tell you, John, that was actually a very dark moment for me because I had this expectation that after I finished these 6 years and I got out of that environment, it was going to be so much better. And I realized it was the exact same thing. And I got pretty depressed. And actually, that was when I did seek some therapy and some help because I thought, this can't be the rest of my life. I can't be counting off how many years until I can retire. And I remember I couldn't sleep at night because I knew as soon as I fell asleep, that meant I would have to wake up and go to work. And it was just a horrible thing when I think about it. I felt very trapped and I felt very stupid. Like, wow, I spent all these years and doing all this. And like, I thought it would be different. And so I toughed it out. I did it for a number of years. I changed jobs again, found out it was the same thing over and over again. And then finally, I just said, you know what? I've been hearing about this model called direct primary care. Lee Gross would write a blog on Sermo, or he'd write a post on Sermo was this old social media site. It still exists for physicians. I'm not really on there now, but this was, maybe a decade or maybe 15 years ago. And he was talking about direct primary care. And I'm like, man, that sounds amazing. And I would fantasize, what would I do if I was going to do that? And so finally, I just had a moment where I said, I'm going to try it. I'll give it 1 year. And if it fails, I'll go work for a hospital. I'll go work for somebody else again. I can do that. But a year went by. It was going great. And here I am almost 10 years later, and I'm not fantasizing about retiring. Although I do want to work a little less because I have other things I like to do, but I am not miserable. I'm not depressed. I enjoy my job. I enjoy what I do. I think that's where some of this evangelical sense comes from, because I do frankly feel somewhat saved by this model. And I think I want other doctors, if they're happy with what they're doing and they're doing great, then that's wonderful. But if they're in the dark spot like I was, that was a very bad feeling when you feel like you have nothing else and you're trapped. I think that's when doctors start to get those dark thoughts where, we lose 400 doctors a year to suicide. And I wasn't quite there, but I could see where it could have gone that direction if I hadn't, had the support that I had. So I think that's where it's like, I want to talk about this and share this model because I really do believe that it can make a difference for a lot of docs out there.
I thank you so much for sharing your story and your journey. I think it's so beautiful to see, I don't know, the evolution of direct primary care docs and to see the healing that happens as they enter a space where they can resonate with their core value of just taking good care of people.
Right.
And
And saying like, I can do this myself. I don't need a team of 12 middle managers to make sure that I've checked all the boxes and squeezed every dollar out of Medicare or done branding or whatever so that they can just come and, crack a whip on me. I am very capable through the DPC model of running a business. Wow, who knew? I had no business training as a physician. None of us really do. There's a lot of fear. We're told you can't do this, you need us. It's very empowering to say, actually, I can run a business. It's a very successful business. I make more money in my DPC practice than I made even when I was making 95th percentile of MGMA at a for profit health system. And I work easily half of what I was working then. I'm not charting late into the night and things like that. And the secret is because I get to do it the way I want to do it. I keep my overhead low and I can pivot. Like if I see something, I say, we could try this differently. We could do it better. What a joy and a pleasure to be able to just make those changes without having to go through a hierarchy and convince some team of people that really don't have that much interest in hearing you out. And generally in the end, just say no. And then you quit even trying. And so that's also that learned helplessness that you develop. So you can be a business owner, you can be successful, and you can take charge of your own career, your own practice, and your entire life, which is something that I never felt before I opened my own practice.
I love that phrase, learned helplessness. I think patients also have that with their insurance because just as you mentioned, like the bureaucratic fatigue and all the, middle management and all those people telling you how to do this and that, insurance companies tell patients that all the time. And
Yeah.
they have this helplessness that they undergo that and when coupled with a direct primary care doc like us, it's so cool to be able to say, no, we can actually do that. And it's actually cheaper if we don't run it through your insurance.
There's nothing better than to say, like, person comes in, like, I don't know what to do. And you're like, all right, let's think this through. We could try this. We can do it that way. We can do it this way. And just brainstorming and thinking outside the box and helping people come up with a solution that works for their needs. And the reason we can do that, of course, we know is because we have time. And because now that we do this model, we actually know how much things cost and what a benefit that is. As a physician, before I did this, I didn't know the tests that I ordered, how much they were going to cost, what a specialist visit was going to look like. It's very empowering to know that information and to share that with our patients. And I think that's another answer to our broken healthcare system is price transparency and letting patients shop whenever possible. Sometimes it can't be helped if it's an emergency situation, but there are times where you certainly can help them figure out a way to do things less expensively, better quality. And sometimes that means not using their insurance.
Yeah. Becky, I want to pivot just a little bit, but it also ties into what you shared with us a little bit, which is physician wellness. You've written a book on this. What's the title of your book?
Yeah, so the title is Physician Wellness, the Rockstar Doctor's Guide. And the reason it's that title, it's kind of a follow-up from my book, How to Be a Rockstar Doctor. And the idea with this is that I teamed up with a psychologist who works at our physician wellness program to talk about some of the challenges that physicians face very commonly and to give tips and techniques from psychology to help them overcome some of those challenges. And I always say that doctors really, probably all of us should just have our own therapist and not necessarily on speed dial, but maybe. I have had to call sometimes just to kind of talk me down from this situation. But there's so much that we can learn from our psychologists and, of course, psychiatrists as well about ourselves. The way I always tell patients, there's only one thing you can control, and that's how you choose to think about things. It kind of goes back to, I love Stoic philosophy, and I think there's a lot of overlap between that and cognitive therapy, which means, again, you can't control anything except how you think about things, but that can be very powerful. You think about things in a different way and it makes you behave differently. And when you behave differently, that affects people around you and it may make them behave a little bit differently. So there's some really cool psychology tips and tricks that I've learned over the years. And so what I did with my friend who's a psychologist is we would just sit down at lunch every Sunday and I would ask him questions like, how would you handle this situation? And what would you tell a doctor who had this happen to them? And I would just take notes and take notes and take notes. And then I typed it all up and he would look at it and he'd go, yeah, that's right. Nope, you got that totally wrong. He would help me I may have misinterpreted what he said. And so together over the course of a couple months, maybe over a year, it may have been, then we had that that book. And so it's sort of just like a starting place for doctors to kind of scroll through and may give them some ideas about some of the common issues that we face. But we hope it'll actually inspire them to maybe, work with somebody themselves for whatever issue they're facing, whether it's procrastination, getting notes done, dealing with the patients that sometimes can be hard. Maybe they're a personal trigger for you because of your own issues that you have, or just people that are a little higher need, and how do you most effectively help them? So I found his advice just so invaluable, and I just wanted to share it with as many people as I could.
That is so cool. I've always been passionate about emotional intelligence. In residency at St. Vincent's Hospital, we had a PhD psychologist on staff. I think all family medicine residencies have
I
this.
think so. Yeah.
And she used to take some of my patients through cognitive behavioral therapy sessions, and I thought, wow, why doesn't this just be taught like in elementary school and again in junior high twice, and then at least in high school and a refresher in your 30s or something like we need these tools, and these they're just it's so simple and commonsensical, but we're just not taught it. It's just
And, I think when you hear CBT or cognitive behavioral therapy, you go, what the heck even is that? Like, it just sounds like this big thing. It's always the answer on the test, though, on the boards. It's like, what
yeah.
CBT? If you see that, that's the answer. But really, it's just about helping people, yourself and others, identify their thoughts, then ask themselves whether those thoughts are accurate, logical, have any basis of fact. So you identify the thought and label it. Then you challenge the thought by asking yourself, is this true? And then you choose a correct, if it's an illogical thought, you choose a different thought. And you say, I'm choosing to think this way. And then you may have to go through that process over and over again until it starts to stick. So my psychologist friend says, you don't have to believe it. You just have to keep telling it to yourself until you believe it. Because we have all these automatic thoughts and assumptions about ourselves, about the world around us, that are not necessarily serving us well and can actually be harming us. For me, catastrophizing is a big one. I'm a horrible catastrophizer. Yeah, I get a letter with an attorney's name on it, and right away, oh my God, my patient is suing me for malpractice, and I'm losing everything, and I imagine myself like homeless. I mean, it goes like that. And then I open the letter, and it's like, oh, your patient's applying for disability. Can you please send records? But meanwhile, I had a mini panic attack because my mind went to this horrible dark place. Those are the kind of things that I do. So I have had to work on that and say, okay, is there any reason to believe that this person is suing me? And if I was getting sued, is there any reason to believe that I'm going to end up homeless? No. So therefore, let's choose to believe likely you're not being sued. Even if you were, you'll be fine. And then telling yourself this over and over again. And it's really a structured process. And it takes work. It's not easy, and you have to do it in a deliberate way, but it's super effective and it does work.
I love that. You also mentioned that people get traumatized from the healthcare system, and the system is so
You,
broken. It's broken
yes.
for us, and we get traumatized. And you mentioned you went through a very dark time in your career. I think people go through dark times in life. We both know we've dealt with anxiety, depression, catastrophic ruminations, all the
Yes.
things. And I think just like recognizing the broken system, that it's broken for both of us, for
Yeah.
people and for the physicians, and stepping off of that provides that trust and time and space to breathe and be better and resonate with your core values.
Yes.
And I've seen so many folks that have been massively traumatized by our healthcare system, and they come in and they're like, you're like the only doctor I could talk to. This is so, because it's like you said, it's like a home environment. Like it's
Yeah.
not like a stuffy office of like, a throughput. You treat them like humans, and you validate their emotions and listen. And it's so healing for both of us. Like for me, for them,
Well,
like they're
they say
healing
that,
me while I'm healing them, and we're both just
yeah.
healing trauma together. It's beautiful.
they say trauma begets trauma. So like somebody's got to break that cycle. And that's hard. Can you imagine the patient comes in and they're traumatized and you're traumatized as a system doctor, they're mad at you and then you're like, then you're upset and you're not going to get anywhere with that. So that's the nice thing about DPC. It does make it easier to be able to break that cycle when a person comes in and tells me, I'm absolutely not going to take any of these vaccines and I'm absolutely never going to do all these things. And some of that may have just come from these negative experiences that they have. And so just being able to not be reactive to that and just listen to that and absorb that and validate those feelings. And then at the end of the visit, okay, I'll take that vaccine. Sometimes you get those surprises, or
Yeah.
the 12th time you've asked somebody suggested that they do some screening test, they go, okay, I'm ready to do that. And so it's just about working with people, meeting them where they're at. I really love the motivational interviewing stuff that we learned a bit about it in our residency with our psychologist too, but I don't think I was in a mental space to really be able to apply it and understand it like I do now, which is, trying to just figure out like what would actually motivate a person to change. I may say you need to, take this statin so you don't have a heart attack, but that may not be a motivator to them. Maybe they're motivated because, something else. So it's trying to figure out, one of my examples with one of my patients who's a very heavy drinker, I was telling her about, this is bad for your liver. These things are going to, and she's like, yeah, 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 yeah. And then I said, let me try this technique. And I just said, what do you think would get better in your life if you quit drinking? And she said, I don't know. And then I would think, is there anything? And she said, well, my husband would quit nagging me. And then she was like, and it was like this light bulb moment. Like I watched it happen. I was like, and she goes, yeah, my husband would quit nagging me. That would be great. And I was like, oh, so that's working. So I do the next thing that they tell you is, so, well, what would be your next step or your first step? And she said, well, I guess instead of drinking vodka for breakfast, I could drink tea. And I'm trying like not to react like you drink vodka for breakfast. And then I'm like, that sounds like a really good start. So then you validate, like, so you're going to start tomorrow, you're going to drink tea instead. Yeah. And it's like, I would not never have thought to say, if you quit drinking, your husband will quit nagging you. Like that would never have occurred to me. So it's trying to draw out from the patient what would resonate with them. And that, again, it takes time, it takes trust, and of course, learning those skills that are so helpful.
Becky, you're healing and she's healing. I mean, your emotional intelligence just to have the bandwidth to apply some of those motivational interview skills and to think compassionately about that situation and how can I hold my tongue and how can I not jump on that, and that's
And
all
I'm
part of
not
our
perfect.
growth and as
I'm
as doctors.
I'm giving the positive examples, and of course, let's not delude our audience into thinking that I'm, perfect and great and do this all right all the time. I have bad moments. I've many moments that I'm not super proud of, and minutes of not wanting to do this anymore, and I quit it all, and that's just called being a human being, doing the best you can.
Yeah.
And so we have some good things that we're proud of, and then days that we continue to work on things and try to get a little better. Maybe schedule vacation.
My hope is that we, the people, the physicians and people, patients can heal together and show up differently for each other, show up differently for our families. I know in my journey, I've been in my direct primary care practice for 8 years, and man, I show up so much better for my kids and for my wife. And there's a sensitivity that has improved. There's a kindness. There's a compassion. Um, and I don't I don't know that it's you mentioned the story about the generational trauma. I guess it was a compassion fatigue is what you called it. But and I felt that I've cared for 3 and 4 generations of people in a rural setting, and then grandma dies from AML, right? Um, and I felt the sadness that comes with, oh, but
Yeah.
her husband I've cared for, and her daughter and her grandbabies, and and all of that is so difficult. But I feel like you can navigate some of those heavy waters if you have the bandwidth for it. And direct primary care, I think, create space for emotional intelligence and healing as physicians so that we can be in those spaces with our patients in a very, just hold space with them in a very sincere way that's beautiful. Um, yeah, yesterday I did a house call to one of my patients, and he's older and he's had a massive physical decline over the past 6 months. He's emotionally and he's mentally very, very lucid and very, very, with it. And he wants to get up and do all these things, but he physically can't get up anymore. And it is just hard for him to endure all the loss that he is suffering from not being able to go to the local play, to not being able to show up at his best friend's funeral that's
Mm,
tomorrow. And
hard.
I sat with him. I went to his home to visit him last night and just sat with he and his wife for 45 minutes and listened to his loss and grieved with him and held that space and spoke with him about it and shared some of our podcasts that we did on grief and loss. And I said, yeah, grieve that. That is hard to do and
Yes.
validate those emotions. And there was a time I didn't have those skills, right? I didn't know that stuff. And it's so lovely, to have bandwidth for a house call at the end of the day,
Oh, it is.
but also to be able to be a better healer, a more compassionate physician, and to show up differently for people. It's lovely.
And we need this for our profession because right now we're facing, unprecedented levels of distrust and dissatisfaction. And I think the only answer to that is to bring the humanity back for us as physicians to show our patients that we truly do care for them. And the only way we're going to be able to do that is if we either figure out how to change this broken healthcare system or if we extricate ourselves from the system and we create something new, which I think is what direct primary care is doing for many of us.
Yeah, and I think as patients and as a community, as small businesses, as they look at direct primary care and what we're trying to accomplish, and really get on board with it, it represents an investment in a grassroots movement of real care, of beautiful healthcare that can be long lasting and enduring and generational. I have a daughter who wants to go into medicine and I'm like, okay, let's do this. And there was a time when I would have said, maybe you should do something different.
Exactly right.
Yeah,
Yeah.
yeah.
Well, I'm so happy to have had a chance to talk with you. I'm inspired by you. I love that you're doing this podcast to share your story and the stories of other physicians and to let patients know that doctors really do care about them and that we really want to be able to be there for you. We really value the relationship. Studies show that the thing that doctors love the most about doctoring is having a relationship with our patients. So I want to thank all the patients out there for choosing to enter into a DPC relationship and for giving us a chance and giving us the benefit of the doubt, even though you may have had some tough situations and experiences in the past. And just know that there's a lot of us out there that are trying to make things better and trying to, and I also say I'm very optimistic about the future. I meet medical students and residents. They're so bright. They're so caring. They want to change the world. And I feel really optimistic that these people really can make a difference. So thank you for giving us that opportunity to keep trying to make things better.
Well, and I look at your efforts and I see how direct primary care has given you bandwidth to really blossom
Yes.
as a person, as an innovator, as a writer. You've written 4 beautiful books and that I know about, and many papers and many studies, and it's just beautiful when you give compassionate, kind, loving, bright minds bandwidth, right? Then they can do really neat things.
You're so right. And I say that all the time. There's no way I'm on 5 boards, which is probably a couple of boards too many. And I write and I do podcasts and I give talks to residents. And there is no way that I could do, maybe I could do one of those things. Certainly not all of them, not even close to half of them. If I was working in a traditional system, if I didn't have control over my schedule, if I didn't have understanding patients that allow me to be flexible with their appointments and things like that. So I agree. It's more than just doctoring, because I think as doctors, sometimes we feel like that's all we are, but we're more than that. We are a human being with a lot of other facets to ourselves. And so doing a model like this does let you explore and be more of a whole person than I think you can be when you're working in the system.
Dr. Bernard, thank you so much for your time today. I have learned cool things, and I think mostly it's just wonderful to share in a journey with you in this direct permacare space and caring for people and see your charisma for loving and caring for physicians and for American families and the beauty that you bring to this space and is lovely. And I appreciate all your efforts, and I'm grateful for your patience for investing in your practice and helping you thrive, and all the impact that you're having nationally is beautiful.
Thanks so much, Dr. Sanders. Am I going to be seeing you at the retreat? You're going to be speaking, I
Yes,
hope.
Shauna and I are both speaking in Tucson at the
Yay! I
Direct
can't
Permacare
wait
event.
to see you in real life and to meet Shauna. I'm signed up. I'll be there, and I'm really looking forward to it.
Thanks, Dr. Bernard. I'll give you a big hug when I see you.
Sounds good.
All right.
Thanks
See you.
again.
Thank you. To our listeners, I hope you learned some cool stuff today. Dr. Bernard, thanks again for your time. And yeah, cheers. Let's keep moving forward.